as well as being recorded. So the live streaming will be going out on YouTube. I would ask you to stay on mute unless directed to speak, which will help our transmission. And we are looking forward to a very interactive and very positive meeting. So the first item, must remember to say that the chat facility is not accessible on this meeting, and so please try not to use it. And one very helpful thing would be, if you are unmuting yourselves, please be mindful not to unmute or mute anyone else, which will help the proceedings as we go forward.
Do you want me to go through apologies and deputies?
Yeah, we'll move on to apologies, and I'll let Susanna do that because she knows all the members, and she can also welcome any new members who have arrived today. Thank you.
Okay. So it is, of course, August. So lots of people are away on holiday, and so on. So I'm not going to go through exhaustive detail, but can I just say a very warm welcome to Pam Donnelly. It's really lovely to see Pam here on behalf of Rory this morning. Pam's, of course, been part of the integrated care system for a long time. I've received apologies from you and Cameron, but Nicola Cottington is here on behalf of West Suffolk Foundation Trust. Ed Garrett is on annual leave, but Richard Watson will be providing the update for the NHS Integrated Care Board on behalf of Ed. Andrew Kelso is on leave, but is represented by Dr. Tanvir Alam. We've also received apologies from Judy Newman, who represents our 3 hospices, but she is represented by Karen Chumley. And some apologies from Maddie Baker-Woods, Mark Shenton, Amanda Lyes, Caroline Angus and Peter Smye as well. And then in terms of just mentioning a few important new people, as well as the very important new person in Councillor Wiles, who of course is chairing this morning. We also have joining us for the first time Wahid Khan from Essex Police. So Wahid is going to replace Leighton Hammett going forward as a member of the ICP committee on behalf of Essex Police. And also, and this comes up on the agenda a bit later on when you'll hear from us both, Hazel Roberts from the Care Quality Commission, as well as a very important new member of the committee. Those are the highlights, Councillor Wiles.
Thank you very, very much indeed. Well, the first part of the agenda is matters arising from the minutes of the last meeting. We are asked, I'm sure that we've all read the minutes, and there were 1 or 2 things that did arise. There was the Thinking Differently Together and the SNE ICS Can Do Health and Care Awards 2024.
We should do an update on those, yeah.
Do we have any update or any questions or query on those at all?
So just to update the committee on those 2 agenda those 2 issues, then it didn't really need to be full agenda items. We held the Thinking Differently Together event around growing up in care. That was a little while ago, but we weren't able to publish the report until after the pre-election period. So that is now available. You've got the link there. It's on our website. And just to let colleagues know that there will be, we're planning a further meeting around growing up in care, working with a number of colleagues and on that at the moment. If anyone's interested in being part of that, please let me know. And then the other thing, nice piece of news is that if you go to our website, you'll find listed at the moment all of the app nominations that have been shortlisted now in our first ICS Can Do Health and Care Awards. So those are on our website. You've got there, and of course the award ceremony will be at Expo. So those are just 2 kind of just updates for people's attention.
Any questions or queries on that at all, please? I can't see any hands raised. Thank you very much indeed. I'll move on to declarations of interest. Please submit any declarations of interest you may have now. No hands raised. Thank you very much indeed for that. So moving on to the update from the NHS Suffolk and North East Essex ICB, which I will leave in the hands of Richard Watson, please. Richard.
Thank you, Chair. Thanks, Chair. Hi, everyone. So a few bits from me in terms of an update. First, I just want to start by reflecting on the situation that we're experiencing across the country. And like you, I'm sure we were appalled and distressed to witness some of the shocking scenes that we've witnessed of violence, racism and Islamophobia across the country. We've been checking in with our staff and partners and listening to what more we can do to build action on some of the messages that we heard through the Uncomfortable Truths process that we've been going through as an ICB and as an ICP. And hopefully we're seeing some of the end of the specifics that we're seeing over the last few weeks. But to want to say that's something that is very present at the moment in our minds across the ICB. I'm sure it's escaped no one's attention that we've got a new government since we last met, and Ed's been meeting all of our new MPs and our existing MPs, and we've got others planned into the early autumn. So we're really keen to ensure that we've got close working relationships with all of our MPs. We've also got a new Secretary of State in the form of Wes Streeting, alongside other senior leaders. I met with him last week in Harlow. He's on a roadshow, which I think is an excellent idea, to meet senior NHS leaders across the country. And I'm really pleased to hear from him and Amanda Pritchard as our National Chief Exec of the NHS that he's really wanting to focus on prevention, strategic shift. He didn't call it strategic shift, Susanna, but that's really what I think he was meaning, clearly, and digital. So it really chimed, I think, with a lot of what we've been doing across Suffolk and North East Essex, but clearly the proof's in the pudding over the coming months in terms of how that turns more into a clear plan and reality. Linked in part to that, some colleagues may be aware that he's also asked Lord Darzi, to do a national performance review into the NHS, and we're expecting that to conclude in the early autumn. We've been asked to provide some bits and pieces, and he's been engaging, I think, with colleagues across the country. So we're waiting to see really what comes out of that and any further changes immediate that there might be. As part of that, you may also have heard that the Secretary of State has asked also to start a process of developing a revised 10-year plan for the NHS, hoping to culminate next spring. There's not a lot of details at this stage in terms of the process, but as soon as I hear anything, Chair and Susanna, I'll make sure that we're linking that through to the ICP, because I'm sure we'll be really keen to have a collective voice into that process around the 10-year new plan. And probably close to our heart also in SNE, the new hospital programme. There's also a renewed review into the future of that. So obviously quite prescient to West Suffolk Foundation Trust. I can see Nicola nodding. So we're hoping again for some further clarity in early autumn in terms of that initial review into the new hospital programme. Also, since we've last met, the British Medical Association has balloted its GP members in terms of taking strike action, which was agreed. There are 10 actions which GP practice can take across the country, including a cap on patient contacts per GP per day. The ICB has been planning for some time around contingencies to keep patients safe, and we've got a regular system call that actually many of you are part of, and we're in regular discussions with both our local medical committees in terms of the action that is and may be taken and any mitigations that we need to put into place. We've also now had our annual assessment as the Integrated Care Board with NHS England, and we're now waiting for the formal rating. That's been slightly delayed, but again, we're hoping to hear something in the early autumn. And we'll be able to obviously provide the announcement of what that looks like in terms of our overall rating as soon as we get that. Turning to finance, I don't think, like pretty much all organisations on the call, it's fair to say our finances are challenged as an NHS in Suffolk and North East Essex. We're just looking at our month 4 figures, but for month 3, broadly speaking, the ICB, ESNEFT and our ambulance trust are on plan. West Suffolk had got some challenges, and we're continuing to work with West Suffolk around a renewed focus on financial recovery. So that's something that's very present in all our minds in the ICB at the moment. In other news, I'm really pleased to say we've now launched a virtual ward service has been launched across SNE. So it's an out-of-hours monitoring service which allows patients to receive hospital-level care in their homes. That's been co-funded by the ICB and the East of England Ambulance Trust. And I'm hearing it's the first. I always pause at this point, first in the kind, because you always then find out there is someone else who's doing it. But I'm being told reliably it's the first in the kind in the UK that's now doing this around 999 and 111 services. And then finally, a financial boost has gone into Clacton, which is brilliant, around a unique mental health hub in Clacton that again is a effort across Tendring District Council, Essex County Council, the Police and Fire and Crime Commissioner and the ICB. It's a facility that is on the High Street in Clacton, run by Citizens Advice Tendring, providing assessment and intervention, particularly for vulnerable residents with poor mental health in that part of our patch. And actually, I have forgot something I should have said also. Just want to say a huge thanks to our departing Vice-Chancellors of both the University of Suffolk and the University of Essex, which we wish them both well. And we're committed to carrying on that strong relationship. I can see Vicky and others on the call who I met with last week, our strong relationship across the ICB with the university sector. So I'll leave it there, Chair. Thank you.
For that, Richard, for a most comprehensive update. We are facing particularly strange pressures at the moment with what is happening nationally, as you've outlined. I'm happy to open this up for questions, and the first hand raised was Paul Little, please.
Thank you, Chair. Richard, on the virtual ward front, if you could let me know a contact to just link in with, I'm keen to see how that might interact with the existing virtual wards. Thank you.
Yeah, we'll do. Liz Maloney in the first instance, Paul, if you drop Liz a note.
Any more questions for Richard?
I've promised him a hard time. So if
I was all.
Yeah, this isn't what I would call a hard time. But we're all being very, very friendly this morning, which is most welcome for my first outing as chair. If there are no further questions, thank you very much, Richard, again for your update. That will move us on to the first key issue for discussion and endorsement this morning, which is the air quality and respiratory health, something that affects each and every one of them. I'm going to hand this over to Andrew Burkhardt to introduce this, and I'm looking forward to a few more questions at the end. Thank you.
I'm not sure if we've got Andrew yet, but we have got Danny and Emma. So Danny and Emma, are you able to kick us off while we're chasing Andrew in the background?
Yeah, I'm sure that's fine. I think we thought we were on later in the agenda, so apologies. Bear with me just a moment and I will get our slides ready.
Thank you. And we will demonstrate that dealing with air quality is a team effort, and we had divided the slides up between us, and Andrew was taking the lion's share. So our inability to get through this presentation might show how much of a team effort it all is.
Fab. Okay. Right, Danny, we might have to fly by the seat of our pants with these first slides. And are you okay for me to crack on, and then I'll hand over to you in a few slides?
Certainly, they're not sharing at the moment. Do you have them?
Okay. Yeah, I'm just bringing them up now. There we go. Right. Hopefully, they are coming across. Okay. Thanks, everybody. Okay. Right. So, welcome. Right, so Andrew Urquhart, unfortunately, yes, isn't here with us just at the moment, but he's our sustainability lead for the SNE ICB. That's something that he and myself, I'm Emma Brinkley, I'm the wider determinants lead for Suffolk Public Health in Suffolk County Council, is working on with Danny Showell, who's the public health consultant from Essex County Council, and also my colleague Rosie Welsh, who's our wider determinants manager, works very closely with me in Suffolk around our natural environment pillar. Okay, so moving swiftly on, so just setting the scene a little bit really, and unfortunately I don't have most of the detail. This was Andrew's slide, but really this was just setting the scene in terms of the impacts of respiratory patients on the health and care system. So there's some data set out there. I don't know, Danny, actually, whether you might be able to talk a little bit more to this, because I'm not familiar with the data. Apologies, sorry.
Yes, certainly. So it's really just to show the impact of air quality on health. And this shows the thousands of patients that are 872, for example, GP appointments and so on. But I think one of the key factors is that 5 to 6% of all deaths are attributable to air quality and the impact of air quality on health. And that's just deaths. There's lots of morbidity that comes from air quality affecting the lungs, the cardiovascular disease, the brain and dementia. It affects the unborn child and most systems of the body. Thank you. If we can have the next slide. So that's why we need to do something about the air quality. Emma, did you want me to talk to this one, or did you want to?
If you're on a roll, you can crack on. I'll take the next one. Thank
well,
you.
As I start to fall over, you jump in.
No problem. And I see Andrew's just joined us, actually.
The cavalry has arrived over the hills. Andrew, if you wanted to take over.
Yeah, I can do, and thank you. And sorry, everybody. I thought we were on later, and I've had some Teams issues, so frantically been rebooting. And good morning. So, and apologies for being late. So, just to pick up on where Danny and Emma were talking there, the point we want to raise here is some of the hotspots, really, of some of the issues, and in terms of what they've both been saying. This. The indoor air quality and the outdoor air quality, the statistics will tell us something, but basically it also shows the complexity. So if we look here in terms of the issues around inequalities, that figure there, 26% in the bottom centre of the highest quintile of the population impacted by indoor air quality, where the building is of a certain energy performance certificate, whereas 2% on the outdoor air pollution next to it. And obviously the previous thrust of the work has been about outdoor air quality and road traffic related pollution and the gases and particulate matter from that. So you look at that and you think, well, actually, that's only 2%. When you look at the housing, there's a quarter. But actually, the two actually do intersect and impact each other as well. So outdoor air quality is still going to affect the indoor air quality. And the point there is, which Emma will be making in a moment, is that there are actually no safe levels of air pollution. So it does disproportionately impact the people that are in the most deprived areas, and it is a serious inequality issue. We know it's one of the wider determinants of health, but those statistics only tell a certain story. And just on the previous slide that Emma was talking about, we do have some figures behind those figures, and we've stratified and looked at certain age groups, and actually asthma and COPD aren't the top admissions, for instance, for A&E. There are other bronchial issues, pneumonia and the like. So actually, the point that we'll be making in a minute is that it isn't just asthma, it isn't just COPD, and the issue of air quality indoor and out will affect lots of other respiratory conditions. We've honed in on asthma and COPD for obvious reasons, but it will still, in those circumstances, exacerbate all of those conditions, regardless if you're in an area of deprivation or not. Thanks both.
Thanks, Andrew. Okay, yeah. So I suppose with these maps, it is really just giving an indication as to where the hotspots are, isn't it, in terms of the health risk in relation to outdoor and indoor air quality. This next slide is a slightly different representation of the outdoor air quality, and really what this is showing. So this is the same SNE locality map, but it's showing the relevant relative concentrations of 4 key outdoor air pollutants, and that includes nitrogen dioxide and particulate matter, which are principally from road transport in terms of outdoor air pollution. What this really shows is an indication of where our hotspots for outdoor air pollution are, with the green areas showing relatively better air quality. So actually across the whole area, air quality is generally good, but those pink and red areas are showing relatively poor air quality, and really that's showing those areas clustered around our urban centres, so Ipswich, Felixstowe, Bury St Edmunds, Sudbury, Colchester, Harwich and Clacton, and is showing really the association between air pollution and road transport around those urban areas. And the people living and working and studying in these areas are being disproportionately exposed to that outdoor air pollution. They're experiencing worse health outcomes because of that, and these are locations that we need to particularly focus our efforts in terms of reducing emissions. It's locations where interventions like no idling campaigns are going to be really, really crucial, because they're so effective really at reducing emissions at source. I just alluded to the fact that air pollution is a driver of health inequalities, and that's because some people are disproportionately exposed because, for example, they may live or work near to a busy road. That's going to affect not only their outdoor air quality but also their indoor air quality every time they open the windows. They might also live in a house that's experiencing poor conditions. It might be experiencing damp and mold, for example. So you've got people that are being disproportionately exposed, but you've also got people that are disproportionately vulnerable to the health impacts of air pollution as well. And that's people, for example, like children, older people, people who are pregnant, people with existing cardiovascular and respiratory disease. And air pollution impacts health outcomes across the entire lifespan, many of which then contribute to people losing their independence through lost mental or physical health. So it just really impacts people in a variety of ways. It's important just to note here that levels of nitrogen dioxide are coming down as we all get cleaner and greener and cars get newer and drivers transition to EVs. But nitrogen dioxide is only one part of that outdoor air quality picture. Particulate matter is in many ways actually the greater public health concern. And if electric vehicles are still a source of particulate matter, so EVs are not the sort of magic bullet to this. And there's lots of research now showing that there is no safe level of pollution. There's lots of impacts on health outcomes seen in patients where exposure to air pollution is below national targets. The World Health Organization recently recognised this in 2021, and they reduced their outdoor targets for nitrogen dioxide and particulate matter, which incidentally happened to be far lower than the UK targets. So I suppose what I'm really trying to say here is that although outdoor air quality is improving, there is no safe level and we need to continue to bring these emissions down. But it also means that as the outdoor air quality improves, the health risk relating to indoor air quality is going to increase. And so we need to also be thinking about addressing those issues too. Okay, I think I'm going to hand over to Danny. Thank you.
Thank you very much. Yes, so this is just the sources of pollution. I'll go through this very quickly. Everybody thinks of road transport as being the key source of pollution, and that is the number one source of pollution for oxides of nitrogen, but it's only the second highest cause of particulate matter, PM 2.5, the small particulate matter that is particularly dangerous. The highest is domestic combustion for particulate matter, but you also have non-road transport as well for nitrites of oxygen, so that's rail, aviation and shipping. You have industrial production and combustion for energy and for industrial processes, and the production of construction and building materials, and even farming and agriculture contribute to particulate matter. So there are many sources, and in fact the second most common important source is other. So it's all the smaller sources that contribute to the effect of air pollution. And as Emma was saying, we're getting better. The quality, it all sounds like doom and gloom because we find out more about how dangerous air pollution is. But the key thing is that over the decades, the air quality in the UK has improved. And as the outdoor air quality improves, the relative risk from the indoor air quality increases. Indoor air quality, all indoor air has ultimately come from outdoors. But what happens in the indoor space is that people add to the pollutants. And the diagram on the right shows how each room in your house can try and kill you, and the kind of where the pollutants come from within your room. So in the bedrooms, it can be the dust and dust mite, the pet dander, or the VOCs, the volatile organic compounds that can affect the lungs. And you also have cleaning products and personal grooming products as well that are a major contributor. And it's worthwhile remembering we spend around about 80% of our time in indoor spaces. So it's hugely important, especially those people who are frail and vulnerable. They're less likely to get out, so they'll spend even longer in those kind of environments. Thank you. We can go on to the next slide, please.
Thanks, Danny. Okay, I'm hoping my colleague Rosie is on. I know she was on the call, but I know she was feeling a little bit poorly, so she might have had to duck away. You are here. Lovely. Thanks, Rosie.
Yeah,
okay, I'll hand over to you. Thank you.
Lovely, thank you. So we've got, you've seen from the slides previously, we've got a really good idea from our data and evidence of the picture of health and air quality levels in the area. What we wanted to do through our public engagement, which launched in June last year, was get an idea of what people understand about this issue. So what they know about air quality and how it impacts their health. As I said, our engagement launched in June last year, and it ran till the end of May this year, and through that time we spoke to just over 3,000 people. We have a research report that will be available, which covers lots of areas, so barriers to taking up different behaviours that would lead to cleaner air. But actually we wanted to pull out some of the key findings for this meeting. I think one of the important things we've found is that the majority of people understood that air quality or poor air quality would affect their health in some way, so 80% of people. What people didn't understand or wasn't coming through as clearly through our findings is how it affects our health. So people on the whole understood that it was linked to respiratory conditions, so particularly coughs and wheezing, asthma. What people weren't aware of were the broader health impacts. So things like it's linked to stroke, linked to diabetes, and links to lower birth weight in babies. And so that highlights, although the awareness levels are good, there's definitely still work to be done around making those links to the broader health impacts. We held a series of focus groups with 77 people from the vulnerable groups that Emma outlined earlier. And it was really important to us that we heard from those groups to get an understanding of the kind of the patient voice, what people need and what people were getting told through their interactions in a healthcare setting. So 91 people from the vulnerable groups told us that they wanted more information about air pollution and its impact on their health. And they wanted this information from a healthcare setting. Emma, would you mind moving the slides on, please? It came out, it's not on the slides, but actually in these groups, only one person from the respiratory groups that we spoke to had been given any information in a healthcare setting related to air pollution and how it might trigger their conditions. As it says on the slide, 23% of the people that we spoke to did have a respiratory condition, and it ranged from asthma through to COPD, various different things. All patients, so all of the respiratory patients wanted information about how pollution might exacerbate their conditions from a healthcare professional, but they wanted it at their annual reviews and from their asthma nurses and from a person in a healthcare setting. So a slight variation on the vulnerable groups, but what it's showing is they all want more information and they all want it to come from a trusted voice. I've put a quote on there, and we had many similar quotes come through our engagement work, and we're happy to share the findings at a later stage, but it just showed how important it was to speak to these groups. And actually our findings in Suffolk mirrored the work that Health Watch have done in Essex and the national picture. So I think, yeah, Emma, would you mind moving on? Sorry, I don't know if that's still Thanks, me Rosie. Or not.
No, I think that's over to Danny now, but I think just also to add that was certainly a recommendation in the Chief Medical Officer's report as well, wasn't it, in terms of giving that respiratory patient information. So thank you, Rosie. Over to Danny. Thank you.
Thank you very much. And it can be very easy with all the facts that we've bombarded you with and that are available to think, well, what can we actually do? And it can feel quite overwhelming. But there are concrete actions that can be taken, and we've divided it just briefly. And this isn't everything by a long stretch, but the essentials for air quality. The first is to raise awareness. That will help to increase the knowledge in the population. So put up with minor inconveniences that might come with things that have to be done if we're going to change the traffic routes and so on. So that awareness is very important and empowers people to take action and encourage behavioural change, which hopefully will come from that awareness, to modal shifts, people taking up active transport and not idling their cars, possibly even changing to electric vehicles, which are less polluting. They're not completely zero polluting. Then looking at the reducing vehicle emissions, so things such as improving the quality of fleet vehicles for those organisations that have large fleets, as well as rerouting traffic, working in partnership. This is no single organisation can take action on air quality alone. It needs to be worked in partnership. So, for example, local authorities working with social and private landlords in order to improve the quality of the housing and so on. It needs to be working in partnership, building houses that are more resilient to pollution, so that they can be easily heated and ventilated as well, because you can't ventilate if you can't heat the property. So having adequate architecture is highly important. So those are just the essentials. If I come to the indoor space, then it's the identifying that people have a problem. So there's the awareness there as well. But then the simple messages of how do you know the quality in your house is a problem, and we need to distill the messages so that there's just a few things that can easily be communicated. Also, maybe training professionals who go into people's houses so that they can quickly detect the signs of that there might be an air quality problem, and coupled with a referral route to get an assessment. No point identifying a problem or suspecting a problem if you can't do anything about it. And there needs to be, that comes onto this assessment section here, it needs to be some way in which housing assessment can be undertaken that says whether the property has functional problems that need to be addressed, and then action needs to be taken on the back of that. So you need to have some way that the assessment can lead to positive change. So that's just a run through of a few of the things that can be done to address air quality indoors and out. Thank you.
Thanks, Danny. I don't know, Andrew, if you wanted to add anything, because we're about to move on to the last slide before we go on.
No, I'll catch it in the last slide. Thanks, Emma.
Cool. Okay, thank you. Over to you then.
Yeah, so thank you, everybody. So really, in summary, you'll see from the breadth and the scale of the report that we've all pulled together, and in Appendix 4, you'll see a list of numerous projects and numerous approaches and initiatives that all partners across both Suffolk and Essex wider, not just North East Essex, have attempted to do. And all of that collective work and a lot of discussions and a lot of sort of integration that is starting to grow organically is occurring. And we can really summarise all of that into some very key level asks. And the last point on Danny's previous slide about this is really about the architecture and the mechanisms to underpin and ensure the next stages of delivery. And if you look at the 4 principles of sustainable models of care, which the ICB have adopted as an approach, the first one is about prevention. And that's about promoting health and preventing disease. And that goes to the root of tackling the causes of illness and inequalities. So what are we asking for around that? Well, as Danny and others have said, relevant training and guides, particularly to support primary care and others where we deem relevant. I'm very aware of system pressures and not doing training or work or an unnecessary burden on colleagues for the sake of it. But we also need to balance that with adopting this model and what do our patients need, especially with now that we need to focus much more and support our primary care colleagues on that preventative healthcare agenda. So that's one of the key asks, and we've looked at other, you'll see the case study in there through Global Action Plan and the GP work and the interaction, and publicity when appropriate to back that up. So that's a real ask to get endorsement to move that one along. Just on that, there is work already starting, so we just want to accelerate, and I'll come to lean in a minute. But in Suffolk Housing Group, all the partners have come together to start to try and unpick these pieces. At Peninsula Practice, the Suffolk Warmer Health team and the practice there are identifying COPD patients, for instance, and how do we link all these elements together? Like Danny touched on, the Warmer Homes team, they've got what are in essentially net zero retrofit funding to make a house more carbon friendly by improved ventilation, insulating it, warming it up. You're lifting patients out of fuel poverty, you're improving the airflow, you're improving the indoor air quality. So we're getting the 2 for 1. We're getting a net zero house, which is delivering our statutory net zero targets, and we're getting better health outcomes. And this is what the nub of this whole thing is about, is that integrated working and thinking. Patient self-care, that's the second point. So this is really about empowering patients to take a greater role in managing their own health and healthcare. And I think we've seen that in spades this morning and in the report, that patients do want to be empowered. The government guidance is very clear. Don't strike the fear of people into this. We have to make this so it's an adult debate about trying to improve outcomes and improve people's opportunity to live well. And we see the overwhelming evidence of, yes, arm us with the right information. Now, we've got experience of doing co-production with patients in this sphere. When we did the inhaler switch program with our medicines management team, the leaflets that were patient facing to advise about switching to lower carbon inhalers and why were shaped through listening to what our patients wanted for our respiratory group. So we know that we can tap into that. So it's about more patient voices, engaging with the public and supporting them, and building it around co-production. And then the third element, this is really about lean service delivery. So everything we've talked about is about streaming care systems to minimise wasteful activity, taking down the barriers, breaking down the silos, getting that system interaction, and making sure that we're working together as closely as possible for the benefit of the patient. And that's where the architecture and the mechanisms come from that we want that endorsement for. Integration. Just in terms of Essex now, working very closely with Danny and the team, and we have an air quality subgroup from our anchors group, which is across the whole of Essex, and all 3 health systems in the districts, the unities and the counties. We're all working together towards shaping that collective air quality strategy to start to make that as seamless as possible. So that's a really good example of that fantastic partnership working together to benefit our patients. And then finally, lower carbon alternatives, prioritising treatments and technologies that lower the environmental impact. It's like the UN Sustainable Development Goals quite clearly state there is no point in having a strategy which lifts people out of economic deprivation if you're not also protecting and improving the environment they live in and tackling climate change simultaneously. And that's what this is about. We're getting more than 2 for 1 here. With the right integrated approach, we can tick lots and lots of boxes for the communities that we serve. So vehicle actions, obvious, but while we transition to lower carbon vehicles, the no idling is something that we really want all partners to pick up and run with again, and work with our staff to do that. You know, it can have a significant impact, as we've seen at the great work that colleagues at Colchester have done on the public no idling campaign there. It can really drive down emissions, and it's something that doesn't actually take a lot of investment, and it'll be good, and it works, and it improves health outcomes. And we've been pushing that in procurement activities as well. Housing, I've touched on it. A net zero house is a healthy house, and that's going to reduce those A&E figures I touched on earlier for people going in, because you won't get the exacerbations with certain conditions that they can trigger. And overall, tackling indoor air quality. So the asks in the paper are 4 or 5 bullets long, but actually that's based on an awful lot of work coming together to go, the patients want the support. We can see we need to equip our frontline service colleagues. We need to break down the barriers and make sure we can make this as seamlessly as possible. And we need to do positive engagement. And also, whilst we're tackling and reducing the outdoor air quality together, a real renewed focus on indoor air quality will give us net zero, will give us health outcomes, will make the service more lean and reduce pressure on frontline services, and there are multiple benefits. So in summary, it's those 4 things, and we would like the endorsement for them. Thank you.
Yeah, thank you. That was absolutely fascinating to me personally. I think one of the key things I'm going to take away from this is the fact that we speak so much about the outdoor air quality, and yet the indoor air quality is very seldom brought to issue. I do believe that we need to shift the focus very slightly to let people know that it's not all about outdoors, but also about indoors. Coincidentally, I've just got the East Suffolk Council's 2024 Air Quality Annual Status Report in front of me. Reading through it, it highlights the improvements of our outdoor air quality, but there's very little about indoor air quality. But thank you. I really did enjoy that. And of course, now we're open for questions. And the first person with their hand up is Mark.
Yeah, thank you. That was a fascinating presentation. I come with 2 hats, really, I suppose, but the official hat I'm here today is with the PPG, chair of the network. So it'd be really interesting where I could find some materials to share with the PPG chairs, because I think it's something most local surgeries as a patient participation group, we could actually have a positive impact on and use it in our newsletters. And so if there's material that I can be made aware of, I'd like to use it, please. So thank you for that. As a district council, as Steve knows, in East Suffolk, I'd be interested to know, I'm going to use Felixstowe Port, but you have talked, I know, about other organisations, what buy-in you're getting from the organisations like the port, because obviously it was concerning to see how much there is in terms of pollution for Felixstowe. And having just prepared our bedroom for decorating and moved the chest of drawers today, I realised how much pollution and dust we have, which none of us probably see, but my wife had a fit when we saw all the dust behind the very heavy chest of drawers. So that's been a real lesson for me. But just the comment is the net zero properties. Steve will be aware, we have a net zero development in Felixstowe, and actually the cost of that has been far more than we anticipated. And speaking to the Green administration at the moment, I've openly said, look, we need to have a sensible approach because it has been really, really expensive. So while I absolutely go with what your ambition is, and some of the other projects I was listening to, I think we have to look at how we're going to afford some of these, but we'll certainly make improvements from where we are. So one's about where do I get materials, and 2 for the PPG, and 2 organisations like the port, what engagement and commitment are you getting from them? Thank you.
Thank you, Mark. Would anyone like to pick that up?
And did you want to come in, or I'm happy to come in on the port bits?
I'll let you do the port bit, Emma, and I can pick up the other bits that Mark's raised.
Okay, thank you.
Yeah.
Okay, so in terms of the port, as I understand it, they have had good engagement with the East Suffolk Council, because I think so. District and boroughs, the local authorities, lower tier local authorities, are the ones that are principally responsible for monitoring outdoor air quality. So they would be the sort of principal partner, if you like, in terms of engagement and activities to actually reduce emissions. And I happened to be looking through their annual status report yesterday, and it looks like there's quite a lot of work going on between the port and East Suffolk Council to tackle that. Their levels are gradually coming down. They are well below the targets, although notwithstanding the fact that there is no safe level. So obviously you still need to be bringing that down. But you can see from the data from the last 4 or 5 years, those levels have been significantly coming down. It does look like there is very, very good engagement from the port around there. I believe as well, our Growth Highways and Infrastructure colleagues are working to set up community hubs and things like that around there as well, to actually start to help port stuff, I think, travel around that area a lot more sustainably as well. So I think it's very positive so far. Thank you.
Thanks, Emma. And yeah, Mark, just in no particular order, but let's go to the elephant in the room, shall we? Costs. I think the trigger for me there is that we absolutely need to be looking more at a whole life cost analysis of this. because the data and the figures that we've cited in our green plan, if you take the cost of creating a more carbon friendly and healthier building up front, it's going to look expensive. But if you look at the health implications over the life of somebody, which is much longer than budgetary cycles and everything allow, and you put in the true cost of the house not being of the right standard for people or of a certain EPC certificate, then actually the cost to the healthcare system and to society as a whole is immense. And I'm going off memory, but I think the figure that we've got in our green plan, and forgive me, I should know this because I wrote it, is something like £5.3 billion cost to the NHS or £5.3 billion if we don't start to tackle these issues. Because although, like we've said, you may be below a threshold for safe air quality, the World Health Organization recommendations are considerably lower. And actually, you're still getting the exacerbations. You saw the figure at the beginning that I was going to present, but Emma gratefully stepped in. We've got, how many was it? 54,000 A&E admissions. That comes at a cost. There's the cost of sending the ambulance out if you have to go and pick them up, and to back, the clinician time, etc., etc., etc. So I think perhaps my take home from this is that we need to do a bit more work around showing the true cost of this, rather than, oh goodness, we've got to build this house and this is costly, but actually we're not taking account of that. What is the cost of actually doing true prevention, which is what we're now about as an integrated care board and system partners. It's the number one priority, is that shift towards prevention. And actually, if we just look at the switch to an EV, for instance, cost money now because of the way the economy is and how the market is, and the switch to insulating a house and doing it in a different way may be perceived to financially cost more up front. But when we look at the full life cycle cost, I think we look at a much more considerable basis of that looks more favourable to us, and why. What was the other one? Was on the PCG chair.
Yeah, materials.
Yeah.
PPGs.
I think what we were talking about as a group, it was potentially having some form of subgroup with all the right subject matter experts from the system, work with the patients and come up with something pretty quickly, actually. So any way that you can engage, and we can go to these other groups to get the buy-in and listen to what they feel they need as well, would be gratefully received. Thank you.
Andrew, can I just add, we do have our idling campaign materials, which are available for all doctor surgeries, and I've been going in and speaking to patient participation groups, and I would welcome some help getting into others. So if I could speak to you outside of this meeting about that, that'd be really helpful.
Yep, no problem at all. Yep.
Brilliant,
Okay,
thank you.
Yeah, thank you, Mark, and thank you for the replies on that. I have 4 hands raised at the moment, and the next one will be Karen Chumley. Karen.
Hi, I'm Karen Chumley, and I'm here representing the hospices today. Thank you, really interesting. I'm a GP by background, really, I found it fascinating. There were 2 particular areas just before I go home and clean my house, which clearly has become urgent suddenly. One is around information, so similar theme. I'm really seeing that I have a responsibility, we have a responsibility as significant employers, and I haven't seen, I'm ashamed to say, good quality information on air quality that I want to share with our employees. So if we could be signposted to that, we'll share it with our colleagues. And then I think there's something that I wanted to challenge myself, who drove in a diesel vehicle today, and halfway around a roundabout thought I should have cycled someday this week. How many of us, a challenge to us, we are the leaders, how many of us used active transport today, if that's an option for us? And can we promote that visibly around active transport and our role as health leaders, health and social care leaders, in using it as an example, both through media and comms with Simon's support, but also as an exemplar to our staff groups. Not available to all of us, but it is available to myself, and I don't do it, and it will be available to others. So a challenge to us, we're the leaders. What example are we setting around active transport and decreasing our own impact on air quality? Thank you.
Thank you, Karen. Anyone like to give a quick reply? Andrew.
Yeah, very quickly, Karen, we'd absolutely welcome that. The ICB is actually committed now to do mode shift staff's travel. We're going to do some sort of staff travel survey, and we've been drafting that. So actually, that would be an ideal opportunity if senior leaders want to lead by example to support that. With the ICB, we've put it in the report. We're predominantly home based now. That our vehicle emissions are down 70% pre-COVID levels, but there's still much more we can do, and certainly around the hotspots. So, we've been looking at using an e-bike in Hadley, for instance, and then how do we educate and support you as leaders and as frontline teams, which is what the Peripatetic Challenge was originally about. But we know from our experience that's going to take a bit of time, and we're just chipping away at that. So anything you can do to support that links into that mode shift, stars shift for the ICB, fantastic and very welcome. Thank you.
Thank you, and I think that highlights this isn't all about the data. It's about the challenges and what we could as individuals do to improve the situation that we have. The next hand I have raised is
Shane Gordon.
Gordon Shane.
Hi.
Shane Gordon.
Okay.
Shane Gordon. Sorry, my.
Don't worry. Great report. I wasn't quite sure, other than the endorsement of the principles, what the report was asking of us today as a committee. So I think we're very committed as an anchor institution in the way that Karen has articulated to the principles behind this report. I'm delighted that I'm hosting, I think, the only clinical lead for sustainability in the NHS that I can find. And we're making good efforts towards this, but it doesn't feel like it's quite a strategy, because it's missing some elements about what specific things we're going to commit to doing as a system, what the goals are for those, and how we're going to measure our success against it. And I think we've heard in some of the other comments elements that might go into that, but it feels like the problem has been presented to us nicely, but the road to a solution needs to be clarified and made much more precise and specific, so that our organisations and us as individual leaders can commit to delivering those. So I suppose the question is there another iteration of this coming which gets us to those commitments? Thanks.
Yeah, thank you. And I actually agree with that, because we are asked to endorse the presentation as it is. We know that we will be heading for outcomes and changes, but I'm sure that we'd like to pick that up.
Can I?
Yeah.
Steve, hi. John Spence here from Essex. I think the challenge, and we feel in this, I absolutely get the point, Shane. And I think one of the challenges we face here as a county is that this is something we need to do as a county, because there are so many relevant partners that do not sit round this table. I'm particularly thinking about the work we need to do with our district and Burn City Council colleagues around housing. All the stuff there is in their domain, and we are taking it to our leaders and chief executives. Our goal in Essex is that this stops being an Essex County Council or individual ICB strategies. It is a strategy that is owned by all the partners in all the different fora. And that is where I know Danny is working on action plans with those relevant authorities. So the move, I think you're quite right, the move from strategy into strategic plan is very much underway, but in a different place.
Thank you, John.
Thank you for that. The next hand raised, sorry?
Zephan.
It's Zephan, please. Zephan Trent.
Thanks very much. My name's Zeph. I'm an executive director at EPUT Essex Partnership. My comment actually builds quite nicely, I think, on what Shane and John have just said. After reading the paper and the presentation, I shared the paper, which is obviously in the public domain, with our estates director at EPUT, and we're working on our estate strategy at the moment, and I asked him to consider what commitments we could make. And I'm particularly impacted by the discussion of internal air quality. So, into that space of what action follows from this really insightful report. my question would be, what commitments might we make as organisations for the people who work and receive services within our walls to improve the air quality within there? And I think there must be much more than that we could do. So, again, building on Shane and John, really interested in what kind of shared actions we can commit to. And certainly I'll be following this up with an e-put with our Director of Estates. Thank you.
Good.
Yeah, absolutely agree with that. The next hand raised is Moira.
Thank you, Moira McGrath, Director of Commissioning Integration for Adults for Essex County Council. I was just reflecting on the kind of interface with challenges we have around housing as a wider determinant of health. So some work that we've done with colleagues has looked at kind of where we have some of the biggest housing issues, and it's generally not in the housing that is directly provided in the public sector. So the biggest challenges are in private rented and privately owned accommodation, which in a way is kind of everyone's and no one's business, because it's not part of the direct responsibilities of the district, borough and city councils, and how we work with individuals, how we support individuals to improve the quality of their housing when there is such a paucity of housing across the system, I think is a challenge. So I think it's really important we look at the interface of air quality with that some of those wider, really crunchy issues around housing and accommodation, because really important we're doing the work on new build, but actually that's a tiny proportion of the amount of housing that we have, and you sort of touched on the kind of multiple sort of deprivation issues where the people in those types of housing will be some of the people who are most at risk. So I think I think it's really important we're looking at the two things in combination when we're looking at the indoor air quality and people's ability to influence that directly themselves.
Yeah, and I absolutely agree with that. We are looking to deliver possibly millions of new houses. How would the delivery affect air quality? Anyone? Andrew, would you like to quick comment on that?
Yes, just really quickly, and what Moira said was a really good point. And I just was checking as she was speaking our assessment of the multi levels of deprivation, and the air quality domain assesses indoor air quality based on housing energy performance certificate and whether it's a D or below, and the outdoor is related to the outdoor air quality that Emma and Danny have been talking about, but also road traffic accidents. So that the 9.3% that we've got there as an indicator of deprivation is there, but actually tied joint last with it out of the 7 indices is also housing and access to services. That's also 9.3. So when you combine the housing and the air quality thing together, you're talking about almost 20% linked together. And that's why this multi sort of agency and tiered approach to look at indoor air quality and housing is so important. So it's a really good point to raise. And and just coming back to Shane and others' comments as well very quickly, we very much wanted to raise the awareness to say, this is what we want to go into the next stages of the strategy. Like Danny and the team, like Councillor Spencer said, are really working really hard on the Essex air quality. I chair a subgroup of the Essex air quality for the climate anchors. We've got over 30 members there of different organisations. We're now talking about alignment with Mid and South, Herts and West and SNE to have the same approach. Emma and the team mirrors and their updates, so actually are coming together today, which if it wasn't clear enough was, this is our direction of travel. This is what is going to form the spearhead of what we want the strategy to be going forward. And we wanted to use this conversation as endorsement for that, to go, right, these are the key issues, this is where we want to go. So if that didn't come out clearly enough in the report, I apologise, but it's definitely what we want from today.
Thank you, Andrew. Next on the list is Stuart Keyboard. Stuart, please.
Thank you, everybody, and thanks, guys, for the presentation. So I think the last point you made, Andrew, is built on what I was going to try and suggest. So I think the bit that we notice here is that this is this is complex, not complicated, and it's lots of interlacing things. What might be useful at some point, we don't want to create loads of workshops, is just to draw a table out of those actions and the different groups in different areas that are picking up the actions. It might help us visualize that a bit, because as you say, you've got a Suffolk and an Essex dimension. You've got different forms and ways of working, so it might help with that. But I think one clear action we can take today is that you're talking about developing some materials for patients and for professionals to help them understand the issues and what they can do. I think an action we could ask maybe for our providers to take away is that could we have a commitment for that to be taken into outpatient clinics for respiratory, and also for the alliances to take into the primary care space, that once we develop them and co-produce them, could we have a commitment to that? Because I think that's a really easier, quick action we can take now, working with the PPGs to try and provide something. And then if we then do that strategic pace around the different groups, I know the Suffolk Housing Board is picking up some of this, that we can just tell that story, and then you can then come back if you've got blockers or issues, and then we can then work out where we go from that. But a clear action for today, and then some wider strategic piece after that.
Yeah, thank you, Stuart. And that action point basically underlines the way forward. Andrew, you want to come back on that?
Yeah, and thank you, Stuart. That would be most welcome. That's exactly where we want to go. And just to add on, just to reiterate Rosie's point that she made earlier about the no idling. The no idling is actually a really quick win whilst this is going on, and a real key tool in our armoury. So we'd like to put that endorsement alongside that, to be honest. So I just wanted to just remind colleagues of that.
Yeah. Thank you, Andrew. Pamela Donnelly. Pamela.
Thank you. I just wanted to pick up on a point that Moira made with regard to housing, because I think with all of this, it's very frustrating that it's difficult to have an immediate and direct impact. But I think the local boroughs and districts have the opportunity to do just that. So most of us will have our own housing stock, or at least influence over our own housing stock, where we can have a direct and immediate impact on the quality of air quality in those homes by some of the adjustments and changes that we make. So if you just take Colchester as an example, we've got 6,500 homes, and we have a direct link into our arm's length management organisation. And it's interesting, actually, because some of you will know that new regulation has recently come out with regard to housing, which puts increased pressure on us to do just that. So, Andrew, I would like to see a direct link to all districts, boroughs, city councils that have their own housing stock, to set them a challenge around this. The second point is in relation to private sector homes, because although they are slightly more difficult to influence, we do set standards for those private sector homes, and we do enforce action against landlords who don't comply with them. And certainly in Colchester, there is a standard around air quality. It would be good to see that right across SNE applied. So those are the points I wanted to make, that there are opportunities. And of course, when we look at the people who are living in our homes and in private sector homes, they will probably neatly overlay with the most deprived in our communities.
Thank you. Andrew, would you quick reply to that, please?
Yeah, very quickly, because those of you who know me know talking is my hobby. Yeah, absolutely. We would welcome that, Pam. This is exactly what the kind of conversation and debate and discussion and support we were looking for today. Is we want to unpick the barriers. There's a real willingness to work there, but this gives us the endorsement to go, okay, the elephant's out the room. Now what we're going to do about it? And I think it's keep picking at all the bits together, get it down on paper like Stuart suggested, and we would welcome that. And in fact, the air quality strategy that Danny's shaping and the update that Emma and Rosie are leading the charge on for Stuart in Suffolk is the same, is trying to set the scene for that strategic direction and then sharing information and unpicking those holes to move it along. So exactly as you've said, Pam, that would really support us to move that forward. Thank you.
Thank you for the reply. And finally, in this question section, we have Sharon.
Thanks, Chairman. Can you hear me?
Yes.
Okay. I just wanted to highlight, really, because I know Laura Taylor-Green was at the last meeting of the Tendering Together Partnership, and she said we mustn't let a particular issue go to bed. And what it was, Gaynor Jarrett, who is the chief executive of Summit, the mental health charity in the centre of Clacton, gave a shocking presentation with current photographs of their clients, and it illustrated the damp, the mould, the vermin, and those clients, due to lots of reasons, are unable to make improvements. She gave one example where a client asked the landlord if they could decorate. She'd saved up the money for some paint, made the improvements. The landlord came round and promptly increased the rent. And that's the position that many of our private renters are in, especially in our deprived wards of East Harwich, Jaywick Sands and Clacton. There is indeed some very, very poor housing that people are living in, and that's illustrated by Andrew's map of the affected areas in SNE.
Yeah,
I'm not really sure what we can do about it.
Yeah, thank you, Sharon. And I actually believe that you have just highlighted some of the very large challenges that this faces. There are so many layers and facets of problems across not only our counties but all across England and the UK in regards to air quality. I don't know whether you'd like to sum up any of the questions before we move to the endorsement, Andrew?
Just a big thank you for giving us the amount of time that you have. I think the comments have been refreshing and honest. It's been a really refreshing conversation. We can see this as an issue. For us, it is about next stages. This will help spearhead the strategies and the details behind it. And as Sharon had quite rightly sort of raised, and this is complex, but there are lots of facets. I think for us now, we've got this data. We need to work through with the alliance teams and look at, right, where are the pockets? Where do we almost start to work first? Where are the things that we can do quickly, like the leaflets, the training, the endorsement, the no idling? And then the short, medium, long term, where are the thorny issues? Do we tackle this cohort, this thing, these areas? We know through the work we've done through the Essex Anchors Group on fuel poverty training, that we can arrange and get things done relatively quickly. So I think a short, medium, long-term approach, and I think actually an ask to system partners, where are these hotspots? There's the work that Essex colleagues are going to be doing in Jaywick, which links this together. So we can learn a lot from those projects, and it might be like the point that Sharon's raised, that there are certain areas that might need slightly different approaches. So I think some sort of continued working group and continuing as we are to unpick it, but you as leaders clearing the path for us, like Stuart raised. If we find stumbling blocks, what we wanted was your endorsement, so that we've got something to go back that's got teeth, that says this is the direction of travel, this is where we want to go, this is why. And if we do get unintentional blockers or barriers, that we've got the teeth with your endorsement to take things forward.
Thank you for that roundup, Andrew, and absolutely agree with you. We do need such gloves off conversations to try, tackle and find next steps forward. Well, we're asked today if we are all happy to endorse the presented report and also the next step forward. Can I take it that we're all happy with this? Thank you. I can't see any hands raised against it. We will move then on 10:40 to the next agenda item, which is the Essex County Council Care Quality Commission Assurance Update. And I'll hand that over to Peter Fairley, please.
Thank you, Chair, and morning, everybody. So just by way of introduction, I'm Peter Fairley, Director for Strategy Planning and Assurance at Essex County Council. It's good to see many of you again after a little absence from this meeting. Would it be, I'm not sure if it's helpful or standard for me to share the presentation. I'm happy to do that. I will take it as read, so I was just going to kind of quickly run through some headlines for it, but if it would be helpful, I can share my screen.
Maybe share screen, Peter.
Yeah, thank you. So, excellent. So hopefully colleagues can see that. So, yeah, just by way of update, as I think hopefully all partners are aware, the Care Quality Commission has introduced a new assurance regime for local authorities in respect to their social care duties. We know they've already been through that process in Suffolk. They've now announced that they're starting that assurance process with Essex County Council. The purpose of today is to share our self-assessment, the key elements of it, but also to seek your support and cooperation as CQC may approach you for your views and also to outline some of the process going forward. In terms of the pack and the assurance approach, the CQC are going to be looking at 4 broad themes. Working with people, including how we assess people and their needs, how we support people, including supporting them to live healthier lives, and how we move towards equity and experience and outcomes. It covers the second theme, how we provide support, including how we work with the care market, but also how we integrate some of our work with health partners, housing and others, and how we work in partnership and communities. The third theme, obviously a really important one, is around how we ensure safety, including how we work through transitions as people move from children into adults, how we ensure safe systems and safe sharing of information between partners, and implement our safeguarding duties. And the fourth theme is around leadership and workforce, which includes governance as well. So just really quickly, the Council's big focus is on quality of life and enabling people to live their lives to the fullest. So really our approach to social care and how we work with people is trying to do everything we can to enable them to be as independent as possible and enjoy quality of life. The CQC have asked us to highlight our top 3 strengths, our top 3 areas of focus and our top 3 challenges. Our top 3 strengths we've highlighted as really positive discharge outcomes. We work really closely with all of our partners across Essex, including obviously in North East Essex, to support a strong home first approach. We do have, by national standards, low levels of permanent admissions into residential and nursing care. So we're very good at getting people home. We also typically have very low levels of social care delays. And we've got a really strong care technology and inclusive employment offer as well. We've got a dedicated workforce and a strengths-based approach to supporting people's independence. And we've got a stable and high-quality care market as well. Having said that, we do have some areas of focus. Carers, unpaid carers tell us that we can do better. And that has been a key area of focus for us. And we've strengthened and implemented a new enhanced support offer this year and going forwards. We have an area like NHS partners as well to ensure that where we've got waiting lists, we look to reduce those and minimise not only the numbers of people waiting, but also the length of time that people are waiting or have been making some positive progress. We also have an area of focus around strengthening co-production and capturing people's lived experience to drive service improvement and shape commissioning intentions. We do have some challenges. Workforce, whilst it's a strength, obviously workforce is a continual challenge around capacity, ensuring that we have enough people, we're able to recruit and retain. Challenge around the mental health system. We know particularly since COVID, the mental health system has been under strain through rising demand and continuing challenges supporting people in the community. And we do also have a challenge around growing demand and complexity. Some of that, again, is in mental health, but also safeguarding. We've seen very significant increases in referrals in terms of safeguarding across Essex. Really quickly on our 4 themes, and I'm not going to go through all this because I will take the papers as read, but on the first theme of working with people, we're particularly highlighted some of the work that we're doing and developments around integrated neighbourhood teams, our care technology service, which is now supporting over 10,000 people, the introduction of the Essex Wellbeing Service that we do to provide enhanced early help and support, and our inclusive employment work as well, which has supported over 430 adults with learning disabilities into employment. But some areas of focus, as I mentioned, we've launched an enhanced carer support offer. We're working with ePut to strengthen early intervention and prevention for mental health. And we are improving our information advice and guidance, and also looking to improve our recordings of protected characteristics, because running through our self-assessment is a need to have really greater transparency and focus on EDI. In terms of providing support, and we work with our care market and our 3 integrated care systems in this. We do a lot of work with the voluntary community sector, who we regard as key strategic partners, not only through the Health and Wellbeing Board and the ICPs, but also at our place-based alliances, and we've got really strong relationships through the North East Essex Alliance in particular. Our hospital discharges work we've mentioned. We have a comprehensive reablement offer, and also some of the shared care record work that we do as well. In terms of the care market, we work closely with our Essex Care Association. We have been improving access to domiciliary care through our market shaping work, and also we've been moving towards paying what's called cost of care rates in recent years. But some areas of focus, we're continuing to look and work around how we can improve support to the voluntary community sector. We do think there is still some opportunity to move to a more consistent approach to the transfer of care hubs. Obviously, we have 5 of those around our hospitals, so looking for more consistent approach across that, and obviously continuing to work with our market to shape areas of support, particularly around areas such as dementia, and also working with our housing partners to optimise the use of things like the Disabled Facilities Grant. On safeguarding and ensuring safety, we do really good work and effective work around transitions planning. We do very proactive monitoring and support to the care market via our provider quality team, and we do some good system work through the ICBs and also through the Essex Safeguarding Adults Board. But we do still have some areas of focus. I've mentioned the increase in demand. We have introduced a new online portal, which enables safeguarding concerns to be triaged consistently and quickly, and also continuing to embed making safeguarding personal. The last theme, I'm coming towards the end, is on leadership and workforce. We have some real assets, particularly around our Essex Social Care Academy, which does a lot of work around continuous professional development and training for our workforce. We're also really proud of what we call our quest approaches around equality, diversity and inclusion. Our quests are where we hand over to a portion of our workforce the ability to run their own quests, so that they can share what it's like to work in adult social care, to work in Essex, if you're a person from an ethnic minority, or if you have disabilities or mental health challenges. And those quests are really bringing really strong insights into EDI in Essex. We do have some areas of focus there as well, particularly around embedding our approach to co-production and capturing more lived experience. We think that is a key area to embed, and also continuing to improve our approach to recruitment and retention. So final minute, in terms of what next, CQC have requested lots of information from the council, which we provided. We were asked to provide a list of all the organisations that we work with across Essex, and on the back of that, CQC will be contacting voluntary sector, carers, advocacy organisations, care providers, health partners. So if they haven't already, they may contact you with a survey, or they may be contacting you for feedback. And obviously, if they do that, we would really welcome that you do take the time to respond to the CQC's request. The CQC themselves will be coming on site. We don't know when, but we will get some notice. We expect them to come on site in the next couple of months. And at the end of it, they obviously will develop a report and publish a report setting out their rating. So final slide in terms of your involvement. As I say, if you do get contacted, we would appreciate you taking the time to give your views, and when they do come on site, there may be an ask for you to join focus groups or provide some further information, and if that request does come forward, obviously we would appreciate your cooperation. So I'm going to stop sharing. Hopefully that's a helpful overview and summary of our self-assessment. Happy to take any comments or questions.
Thank you, Peter, for that comprehensive presentation. Opening for questions, and I have Karen Chumley with her hand raised. Karen.
Hi, yes, Peter, thank you. I'm keen to know more about the comprehensive bereavement offer. That's an area where we're keen to collaborate. And the last time I took that conversation forward strategically, at that point I was told there were no plans. Now I'm not in the operational detail, and it may be that it's moved on and I don't have visibility, but really keen to understand your work there and to make sure that we're working effectively together. So I welcome a conversation, and if you could just give me a headline on it now, and we can take the rest of the conversation outside. Thank you.
Thank you, Karen. I'm afraid that's outside my operational bit as well, so I think I will need to get back to you, unless Moira, my colleague on the call, might be aware as well. But we'll certainly link up offline.
That being the case, I think you need to take that offline and give an answer there. Thank you. The next hand raised is Paul Little.
Thanks, Jim. Thanks, Peter, for that comprehensive overview. It looks like Essex in a really good place in terms of preparation for CQC. As you know, Suffolk had, I was going to say privilege, but that may be the wrong word, the opportunity maybe of being in the pilot arrangement. And if it's of any help at all, I'm sure we'd be very open to a conversation about our experience of that. But as I say, it looks like you're very well prepared and comprehensively self-assessed everything in relation to that, but there's an open invite there if that should be helpful. One thing to note, not directly in relation to the inspection process itself, was I noted that like Suffolk, the issue of increased demand has come up, and I wonder if there's an opportunity for Essex and Suffolk to do some work together about the nature of that demand. Certainly in Suffolk, we had seen a rise in numbers, but that's quite plateauing now, and it's more about complexity and extent of need where the increases in demand are happening. And I wondered if there might be an opportunity for us to work together on some deeper analysis to understand that demand and our responses to it. Thank you.
I think on both of those offers, I think that would be really appreciated. Like you were starting to kind of get under the skin of some of that, and I think joining up to see what the commonalities are would be really, really helpful.
Thank you. And the final question in this segment will come from Andrew.
Yeah, thank you. Just on that, Peter, I mean, we're looking at CQC under environmental sustainability section as well, and similar to other colleagues, a reach out there, because I've just been mind mapping and looking at what are we doing and how are we going to comply. And I just think the example of us is understanding the impacts of our activity, and we're doing something about it. And there are several subsections to it. But I think what we presented as a team to you today is a really good example of where we are integrating that to get those benefits. But we don't want to rest on our laurels. I'm sure there's a lot more that we can be doing. So if we want to take that offline, I think that would be a useful conversation in terms of the environmental sustainability element, because we do need to reach more into support like Sharon and others in the voluntary faith community sector, which we're well aware of. So that would be a useful conversation to have and take as an action for that.
Yeah, excellent. Thank you, Andrew. That's a good suggestion. We'll pick that action up as well.
And just to add to that, we're doing quite a lot on social value in our procurement, which is, I think it's been really interesting about kind of challenging ourselves to think about the kind of wider environmental and sustainability impact in the work that we're doing. And that's sort of on the back of the council as some of the issues that Councillor Spence raised earlier. So really happy to link up on that, Andrew.
Yeah, we can do that more. I think we intended to do a more wider rollout of the sustainability impact assessment and tie that together as part of that. So yeah, let's definitely take it off, because I'm planning something for the autumn. So it'd be good to do that together rather than in isolation.
Thank you for that. And again, my thanks for the excellent presentation. We are asked this morning to note, and I'm sure we're happy to note the presentation, unless anyone has any further comments. No, that being the case, we will move on to a break, believe it or not, which is always welcome. Could I ask you all to turn your cameras off and remain on mute for exactly 10 minutes, and we will return at
11.
11, according to the boss. Thank you.
Okay.
Well, welcome back all.
Is that enough time to boil the kettle?
Chair, apologies for my lateness. I'm just joining now because I've had another meeting I couldn't avoid.
Lovely to see you, Kathy.
Yeah, thank you and welcome.
Okay.
Okay, it's 11:05. I hope we are all charged with a cuppa, and we will move on to the ICS system assurance and engagement with Care Quality Commission, which is in the very capable hands of Suzanne.
Okay, so I'm going to do a double lap with my colleague Hazel from CQC is going to talk to you in just a second. So I'm going to take the paper as read because there's quite a lot of detail there in terms of the suite of dashboards that we've attached to the paper. But this is basically an update on a piece of work that we're doing jointly at the moment with colleagues at the Care Quality Commission to explore how we can develop a kind of regular relationship between the integrated care system, so collective partners in the integrated care system, and the CQC. One of the kind of core elements of this was the idea that there should be some sort of regular meeting that took place between CQC and the ICS. And the proposal that we've brought to you previously was that we might do that through the Integrated Care Partnership. So Hazel joined us at very short notice at our last meeting of the ICP committee, and she's here again today. But you'll see in our paper that we've set out, if you like, a kind of proposal for how we think we might manage this relationship going forward. So in section 2 of the paper, we've set out kind of some proposed arrangements. So to use the ICP committee as a regular kind of forum for engagement between the ICS and the CQC, and to do that by including basically having a seat on the ICP committee for the CQC, so including Hazel as a member of our committee. That would mean that she'd have the joy of all the emails and contacts that all of you have from me regularly about not just our ICS committee meetings, but also other meetings and other conversations that we have within the system. So things like our system learning events and also our Thinking Differently Together forums and so on. And then more specifically, to try and kind of frame some conversation about how are we delivering collectively as a group of partners locally and as a integrated care system. Of course, we've been developing a suite of system dashboards now for some time to try and kind of have an overview of that. So we've just updated those, and you've got an updated version of those dashboards attached to the paper. And as we've previously discussed, those dashboards kind of run through a range of different sources of information, but all framed around the 4 purposes of integrated care systems. One of the things that we've included now in those dashboards, I think it's on around about page 6, is for the very first time as an outperson work that my colleague Liesl Kennedy has been doing, working with Janet Wood, who is a non-executive for the ICB, but she's the chair of the audit committee, has been bringing together colleagues to look at the concept of how we can have a kind of system kind of risk, overview of risk, and we've included a dashboard on that for the first time. So another proposal is that we intend to circulate and update those dashboards maybe 3 times a year, and to include on our agenda for the ICP committee a conversation about what's in those dashboards and what that's telling us in terms of maybe what our focus should be as a group of ICS partners as well. And of course, by sharing those dashboards through the ICP, we've been making those dashboards regularly available on our ICS website as well. So those are the kind of arrangements that we're proposing to take forward in terms of beginning to develop that regular relationship between ourselves as ICS partners and CQC. I'm going to hand over to Hazel so she can tell you a little bit more from her perspective about what CQC would like to get from these conversations. But just to say that one of the things that occurred to Hazel and I when we were preparing for the meeting this morning is that having sort of now got over the line a suite of dashboards and an opportunity to talk about them, we thought in preparation, so the next time we do this, we thought it'd be really good to have maybe a few colleagues who might be interested in sitting down and looking at those dashboards in advance of the meeting to kind of draw out what some of the key points are, so we can include that in a kind of cover paper in future. So we might do a little bit of a pre-look at the information before the committee meeting itself. And so if anybody was really keen to look at dashboards and information like that in advance of the next meeting, next time we do that, which is in about 4 months' time, please let me know and I will happily fill your time with that activity. However, so that's a little bit of an overview about the arrangements that we're put forward and we'd like the committee to endorse this morning. But I'm going to now hand the floor to Hazel, who can tell you a little bit more about what, from a CQC point of view, they're hoping to get from developing this relationship with us as an ICS.
Thank you, Susanna, and morning everyone, and thank you very much for inviting me to your ICP meeting. It's an absolutely fascinating meeting and really valuable for me as a representative of the regulator for health and social care. So my name's Hazel Roberts. I'm a Deputy Director at the Care Quality Commission, covering network operations for Hertfordshire, Suffolk and Essex. So that's my patch, and I'm responsible for all regulated locations in respect to health and social care within that geography. So I just want to sort of say I'm separate from our ICS assurance function. So this isn't about me kind of assessing you in terms of how effective you are as an ICS. It's about me as a local leader understanding the issues and themes across the health and social care landscape of Suffolk and North East Essex. And as a regulator, it's about offering intelligence, data and expertise on local issues. So me and Susanna have talked about our aim of this work and what we want to achieve. And I think, what we've kind of settled on is our aim is to work together to tackle health inequalities through the lens of regulated services. And also, from a CQC perspective, to use our independent voice in the State of Care report to reflect the joint challenges and successes of local areas. So really, it's to collaborate together to drive improvement across the system and to share learning and support for providers. So that's our kind of our aim, which is quite a chunky aim, and we'd be really grateful for anyone who's willing to support us in looking at the dashboards, as Suzanne has said, to kind of try and unpick what the biggest system risks are and how we can support from a regulatory point of view to tackle some of those. So I don't know if anyone's got any questions, Suzanne, or if I hand back to you.
Okay, so just in summary, in terms of the paper we put forward, it's proposed, as I said, the kind of regular conversations of bringing CQC around the table as a regular member of and a regular partner in the system. We're also proposing to use the suite of dashboards as a focus for our conversation on a regular basis. So we really would welcome your feedback on that. And the rest of the paper just really updates you on the work that's been going on to update that suite of dashboards, which we see as an ongoing process, basically. But it does now incorporate that very key additional section, starting to look at risk in the system. And so we'd be grateful on your feedback on that as well. So I'll stop there, and I can see that some hands are already up.
Yeah, thank you for that. And the first hand raised is Nicola Cottington. Nicola.
Hi there, thank you. My name is Nicola Cottington. I'm the Chief Operating Officer at West Suffolk Foundation Trust. Really welcome the collaborative approach and kind of being part of the ICP. That's fantastic, really good to see. On that specific point around risk, the dashboard that's shared on page 9, I was looking at it and I reflected on how actually, although we describe ourselves as the National Health Service, even locally, we'll be coming at this issue of risk from different perspectives and using different methodologies. So I know that people are invited to kind of click on and look at more, but just looking at the headlines, I would be really keen to be involved in some work to sort of further develop that, so that we can distill from that kind of what our actual system risks are, because you can see that we've all sort of approached it slightly differently. We have different naming for our different types of BAF risks. So yeah, that kind of really struck me, and I wondered also how we can express through this some of the improvements that we're making through collaboration within the ICS. So thinking particularly around the provider collaborative that Shane and I are involved with, but there will be other collaborations as well. So rather than, and I'm not saying that it comes across as a collection of separate organisations, but I think that we could strengthen that part of it as well.
Okay, I can see that Janet Wood's got her hand up, and Janet, of course, has been chairing the group around this work. So I can suggest that Janet might want to come in at that point.
Thank you, Nicola. That is great to hear that you want to be involved. At the moment, the work is being led by audit chairs and individual risk management experts in the NHS organisations. That is simply a lock together of the NHS organisation BAFs. What we want to do is develop a system risk and assurance framework, which is focused very much on the system ones. So if we can extend that group to include other people, that would be incredibly welcome. Our local authorities are engaged, but we're not putting forward their risk registers yet, but we want to have that whole suite of information. I think, Susanna, you and Hazel's suggestion that a group comes together to look at this in advance, that would be absolutely fantastic from my point of view, because then we can start to steer what the discussion is around risk and what we can do together. The air quality conversation we've just heard, I'm looking at that from a system risk perspective. How do we capture that and how do we assess that? And there are lots of other things out there. So this is very much at the embryonic stage, but I think there's so much to do. But we've got to be really careful that we're not just creating another set of documents. They've got to be adding value and making improvement, and predominantly to make sure that we achieve the 4 aims, which we're here for. So the wider we can spread this, the better. Thank you very much.
Thank you. And the next hand raised was Shane Gordon. Shane.
Thank you, Chair. Nicola and I talk very often, but we haven't talked about this, but I was going to ask about risk as well. So the CQC approach is brand new in this space, and undoubtedly it will mature over time. I think for the acute sector, where it's more mature, a lot of the conversation is about awareness of risk, but also proactive response to risk in exactly the way that Nicola and Janet were talking about. So I don't want to labour the point, but I think that kind of demonstrating that we know where the risks are and what we are doing about it is a really strong feature of our interaction with the CQC. It may not yet be for ICBs, but I think being on the front foot with that will be a good thing. And the development of that system view of risk rather than individual fragmented views of risk, I think, is a really important part of that. Does that lean us towards a system BAF or assurance framework which lifts those risks up into a very small number of very strategic themes of risk, rather than trying to take the individual granular risks and knit them together awkwardly. Yeah, it's not my area of expertise, I have to say. Thank you.
Yeah, I think it's fair to say, Shane, that it's not been an area of expertise for any of us, but we're working our way through this at the moment. So I'm going to imagine that perhaps yourself and Nicola might be wanting to help us kind of work our way through this issue as we go forward. And that's very much kind of, the conversations that Hazel and I have been having is how do you take a system view genuinely as opposed to the kind of organisational focus that we have. And I think SNE is in as good a position to try and solve that problem as any other system in the country.
Yeah,
thank you. Stuart.
Thank you, Chair. So I was just thinking about the assurance document, and I think, Suzanne, you were talking about doing some deep dives or people reviewing that. I think for me, it's kind of two angles around the data and the information. I think one of them is how do we use it to drive what needs to come to the ICP for discussions, recognizing there is a huge amount of metrics in there, and potentially what we can have the most impact on. So I think that's the first question. So there's a bit of a how does it drive our strategic agenda, and then also secondly is there will be themes across that is how do what papers get brought to the ICP, how do they respond to those challenges. So we've always got kind of that continuous improvement process on there, because I think sometimes we look at all those indicators, and most of those indicators many of us will be aware of, they're not where we want them to be, but I think it's the moving beyond the telling the story, as Shane was talking about earlier around the air quality, and often Shane's really good at taking us back to we know the story, but what are we going to do about it? So I think that's the challenge with the dashboard and the assurance piece, is how is it going to drive another conversation or another piece of work, because if not, public health, we love to tell a story about our data, but we need to be using it about how that's going to bring change as well.
Yeah, happy with that. Thank you, Stuart.
Yeah, thank you, Stuart, and that underlines my feeling as well, that there's lots and lots of data out there, but what are we doing with it? And move on to Hazel Roberts, please. Hazel. Prima. Yeah, missed you. My apologies. Prima.
Sorry, that's okay. So my question, Hazel, is, I represent care providers in Suffolk, and yeah, we obviously have had a long history with being inspected by CQC, but where do we sit within this dashboard? And because it's slightly different, compared to local authority inspections and health. So that's my question. I'd just like to ask you how we can work together, because there are a lot of questions that care providers have got at the moment, especially with the single assessment framework. And, because there's so much confusion about it and the portal, etc., they would want to ask for a little bit more direction in how we move forward.
Hi, Prima. Thank you for that. That's really helpful reflection. So I absolutely want to work with our care providers around our single assessment framework and what's happening at CQC at the moment. I'm sure many of you will have seen the interim Penny Dash report that highlights that CQC have many challenges we have to overcome at the moment, and we very much want to work with our partners to overcome those. So I'm happy to have a separate conversation with you, Prima, about how I can support local care forums. But in terms of this suite of dashboards, one area that we've kind of recognised is kind of underrepresented is kind of our adult social care provision and our care provision across SNE. So that's something that CQC will be looking to kind of see what data we can provide to support around kind of having conversations about themes and trends within adult social care and how that impacts on other parts of the system. So Susanna and I were having a discussion the other day about case tracking people's journeys through care pathways and looking at some more qualitative information to input into the dashboards as well. So, we can look at, is there a particular issue across SNE around the mental health pathway and how that interacts with adult social care and hospitals and inpatients and outpatients and community provision, etc. So I think there's a lot of work we can do here, but I suppose I put my hand up initially, Chair, just to say that this is a pilot approach. This is something that we're piloting across SNE. So I'm really grateful of all the feedback that we can get about how this is working and how it needs to develop over the coming months. And just a huge thank you to Susanna for her support.
Thank you, and I'll endorse that. Thank you to both Suzanne Susanna and Hazel for the excellent presentation. We're asked this morning to endorse the presentation. Are we all happy with that? Any other questions can be taken offline. That being the case, thank you very much indeed. And we will move on to ICS system learning and uncomfortable truths. How, what reports and so what? So what? 22 things we can all do to tackle the systemic injustice. And I'll give this over to Sharon Roddy, please.
Thank you. So I have got, what I have got is a new laptop. So I'm just going to attempt to share a couple of slides, which are just really acting as an aid memoir. Rather than, there's nothing new in them at all. It's just some of the summaries from the reports, just to help with the conversation. So I'm hoping that's going on slideshow. Is that on slideshow? Any, Susanna? No, not yet. There. Am I there?
It's very small.
Oh, is it? Oh, good Lord. I don't know what's happening there. Right, let me try again. Right. Is that showing? Sorry. I don't need to show it. It's fine.
No, there's nothing showing.
Oh, okay. Let's forget all that. So we're running out of time otherwise. So just to summarise, so it was only really what was in the summary of the ends of the report. So the point of uncomfortable truths, and we have talked about it before at the ICP, but not for some time. So I thought it'd be helpful just a tiny bit of context. So the idea of the uncomfortable truths campaign really is around turning that curve on the entrenched systemic inequalities that people experience, so many people experience in health and care. And it's part of our system learning commitment that we have in our system. So part one, we have talked about before at the ICP. It was held in late 2023, and it was looking at why we need to turn the curve, why we haven't yet turned the curve as much as we would like on those inequalities, health inequalities and inequities. And we recognise that we're not doing enough, and we recognise that we're not doing the right things. And they were really interesting discussions. It was a very open, I think that's something about our system, it was a very open discussion. We then held part two in March 2024, and that is linked to that is in your papers. And we looked at that event on how we change our approach. And we identified that we need to change in a few ways. One is how we interact with others, diverse groups and communities, how we build relationships with those groups and communities, and also how we interact with our workforce. We need to understand better we need to change how we understand the complexities of health inequalities and apply that to our policies, our practice, our decisions, our governance. We need to think about how we can influence, because we all have power sitting in this room, how we can influence through our wider roles as anchors, as employers and so on, and then how we can put that learning into our vision and strategy. So always, because we work at a system level, maintaining that system strategic approach. We then held an event in May 2024, and again, the report's available, looking at what we can do as individuals, as human beings, as individuals, as professionals, and that may relate for some of us to our codes of conduct and our codes of ethics, what we can do as organisations, and then obviously what we can do as a system. And we came up with some actions which are focused around being curious, being person-centred, being fair and inclusive to those who we serve and those who our workforce, and continually learning as well. And I just want to say I'm really grateful to those who contributed to all our events, either as speakers, as panel members, as participants. It was really, really positive and heartening, actually. So so what now? So we have a document that we've presented in your papers, which is entitled kind of So What Now? Because we've had those discussions, we've thought about where the problems lie, where things are going wrong, what we could do. So through that, we've arrived at 22 actions that we can take as a system, that everyone can take as individuals, professionals and organisations. We have done a lot of thinking and we need to make sure that we maintain that momentum. So we're focusing on 3 areas that we focus on our first ever event, which is our services safe, integrated, equitable and compassionate. So that involves things around understanding the issues of quality and compassionate care. We're looking at, is our health and care system a fair and inclusive place to work? And that is around inclusiveness, valuing and embracing diversity of our workforce and the people we serve. And it's also about safety, physical, psychological, sexual safety. And, Richard Watson at the start of this meeting, early on this meeting, talked about how staff are not feeling safe today. So the importance of compassionate leadership in that is vital. And then the third element of those 22 actions is around, are we continuously learning and improving based on evidence and experience? And that's focusing around co-production, around making sure that our decisions, our plans, our delivery is evidence-based, and also that research, because we want to, if research is part of that evidence, we need that to be inclusive, so that research is high quality and understands the complexity of inequalities as well. So every organisation, every partner is responsible for equality and equity. So we're inviting partners to self-assess against those 22 things. And there will be progress. None of this is starting from zero. There will have been things that you have done, that you have made progress in. Peter Fairley was just talking about some of those earlier on. The challenge is to move further and to think and to do differently. So those 22 things are they're quite specific, but they're also quite flexible, so that you're able to look into how these fit into people's individual, professional, organisational roles and purposes and activities. And this is not about something that is a new strategy or a new thing to do. It's about checking and assessing whether you are implementing your strategies in the right way, and your plans in the right way. We're offering support from our team, from the ICP Secretariat and from People and Communities Committee, who we'll be hearing from momentarily in terms of their terms of reference. But with your agreement, so we're asking today, obviously, to receive and approve those 2 reports and the 22 things, but also receive those reports, but approve those 22 things and our invitation to self-assess. So if you agree that today, then Fanwell Muttenbury, as Chair of People and Communities, will write out to partners afterwards to invite them to self-assess and to offer that support. And we know that the ICB has already committed to self-assessing, so they're making a good start. And that was all I was going to say, primarily.
Thank you. Happy to throw this open for any questions or comments.
Tanvir.
Hi, can you hear me?
Yes.
Okay, so firstly, I'd like to thank Richard for the statement that was sent out earlier, especially with the backdrop of recent events and highlighting Islamophobia. We are one of the few ICSs in the country which actually had the conviction to use that expression. So I appreciate and respect that. As a man of Muslim faith, being supported by allies in this time of crisis is essential. We had a very good cultural safety workshop which was done earlier in the year. I'm I'm a little disheartened to say the uptake on that after that has not been to the level that I was hoping for. And the various powerful people in this room here should really be pushing that forward in their individual teams and spaces. Because I think cultural safety, if it was ever needed, this is probably one of those situations where we have those tools and resources developed by the NHS central team under the guidance of Professor Mala Rao, Naveen Evans, Geeta Menon, Vijay Nair, Sujesh Bansal. They were kind enough to come and do this workshop for us. And I think disseminating this into the individual spaces is the need of the hour. The question that was mentioned on an LBC interview is, how do you deny healthcare to somebody who is discriminatory or a misogynist or a racist or whatever? You can't. You have to continue to provide healthcare. Compassion for our patients is at an all-time high as we are clinicians, but our compassion between each other as professionals still is lagging behind. I think it is important to take these tools and not still look for other resources, because we are the first ICS in the country to actually take this forward, cultural safety. It's a need of the hour, and I hope people who are here, the people in positions of power, will take that forward and actually start embedding those changes, because I think change must come now and not as a construct of our conversations for the foreseeable future. Otherwise, we will still be stuck in that loop, in the infinite loop of what do we do, what are the resources. We do have those resources, and it is about time that we actually started using them more effectively and more appropriately, given the backdrop of the challenges that we're facing. Many of my colleagues are quite vulnerable right now, and I've heard so many conversations of people who are contemplating, moving elsewhere if the present situation continues. I live in Norwich, and Norwich is supposed to be a peaceful place, but we have a system called reports of potential demonstrations tomorrow, even in East Anglia. So I think it is an important thing which I have said today, and it's a call to arms to all of you to embrace this cultural safety workshop and actually start embedding these practices. I am happy to work with Susanna and Sharon to roll those out at pace. I think the need has never been more acute than it is now. And, in the words of Marcus Aurelius, what we do now echoes in eternity. So I hope these words will resonate with you moving forwards. Thank you.
Is it possible just to come back on that very quickly, just to say, Tanvir, that University of Suffolk are looking into rolling out that training. They're going to come back to us, but they're consulting with their deans at the moment. So that's one positive. But absolutely, I agree that we need to do that, do more.
Yeah, thank you for that. And I'm sure that we all agree with you, and we all need to own this and make a difference. The next hand raised was Panwell, but he's taken his hand down. Mark, please.
Yeah, thank you. I fell out of the meeting for some reason, so if this has been covered, then forgive me. I was looking at leadership behaviours, discrimination, bullying, etc., and it's rather concerning what the figures are in 2022. Particularly here in SNE, which fell by nearly 2.75%. I don't know what the numbers are for that. So that's the concern as a patient looking into the organisation and thinking, well, how well are they being run and how fair is the organisation? And it reminds me of the Lucy Letby inquiry when senior managers were trying to report concerns and they perceived to have been sort of told to get back in their box, for want of a better phrase. And the other one, which I couldn't see in there, is there any data to say which those who the staff referring to were clinical or non-clinical staff? It's just a bit of a worrying picture for this doesn't paint a very good picture, albeit it's 18 months old. So they're my observations. I don't know if there's any comments on any of that.
Do you want me to give some response?
Yes, please.
Yeah. So they're based on the NHS. I think the data that you're talking about is based on the NHS staff survey. That tends to talk about bands. I'm not sure. It varies each year slightly, but we can look into that. But I think it talks about bands rather than professional roles, if that makes sense. So, and it's completed anonymously as well. So it's difficult to drill down, but kind of rightly so in some respects, because people need their anonymity. I'm not sure it's that different to the rest of the country, though. I don't think it's, none of it's right, none of it's justified, obviously. But I don't think we're that far off the national statistics.
Yeah, I mean, you look at them and think, and most are under 60%. And what would be a realistic target that you should be trying to achieve for the general
60%,
welfare?
Sorry, 60% for. I was missing.
But if you look at the survey, there's nothing better than 59.60 of people who feel effectively satisfied. Surely that should be higher than that. Is there a target that you aim to achieve?
Oh, I think that would be there will be workforce targets. I'm sure there will be. Perhaps I can drop a line to you, find out some information, drop a line to you separately about that.
Okay. All right. Thank you.
Thank you.
Thank you. We have 4 hands raised before we close this segment. So quickly going through. Could Shane next, please?
Thank you. Firstly, thanks to Sharon and Tanvir and everybody who's been involved in this work, which I think is courageous to do this work as transparently and explicitly as we have done as a system. I also want to just personally state my utter revulsion at what's been going on in this country over the last couple of weeks. What gives me hope, though, is the level of public support for people with protected characteristics who are the target of this appalling behaviour. And the one phrase that stood out in my mind that gave me hope was, "We are many, they are few." And we have to hold on to that. In terms of the way forward with the report, the only comment I wanted to make, really, I might just comment on Mark's points, if I may. The NHS is looking at this and publishing the data. I'm not seeing that from other sectors. So we actually don't know what this is like in other sectors. What I hear from colleagues who've worked in private industry before coming to the NHS is the NHS is far more tolerant and fair, albeit having many failings, than some parts of private industry. So it may not be ideal, but it may not be the worst that there is. We just don't have the data. In terms of the sort of comment I was going to make, it was in response to Tanvir that we can't do anything about patients who behave badly. We can, and we do. And we exclude patients from our services if they are racist or discriminatory or abusive. And we will only treat them for saving life or limb. And we do that on a routine basis. I can see Nicola nodding as well. It's very hard for us to do, but we do it. And we need to stick to that standard that we expect everybody to be treated with respect. Thank you.
Thank you, Shane. I'm sure that we all agree, especially with the first part of your comment and the final. Mindful of time now, I'm moving on to Jyoti, please.
Thank you. I just wanted to take a bit of a different angle to the one that's been taken so far. I think what's really concerning to me is the rising access of private primary and secondary care, which I think is absolutely widening inequalities. And people might say or think that actually it's taking pressure off the NHS. It's actually doing the exact opposite, because there's a finite number of skilled and qualified staff. And what is absolutely shocking to me is that people are accessing secondary care, private secondary care consultants, and then being pushed to the top of the list for care. And, that to me is utterly shocking, and we should not allow it.
Absolutely agree with that. We'll move on now quickly to Prima.
So I will be quick. I just want to echo Tanvir's concerns, but this is actually quite widespread in social care. And we are now, as you're aware, very reliant on international recruits. So most of our care homes and domiciliary care have got lots of staff who come from overseas. Now, they're not treated very well by clients. And although we've brought this up, frequently, there's not enough in the system to actually support us there. So our staff have got to put up with a lot of abuse, and which is actually it's totally unacceptable. And although we have zero tolerance policies within our workplaces, it's still not enough. So there's very clear racist practices, and also their agenda issues too. So it's something that we need to look at in a greater form, and see if there's something that we can work towards jointly to put a stop to this.
Yeah, thank you. That comment is most welcome. No one should suffer any abuse in any workplace, especially when trying to provide care. And finally, last on this segment and questions will be Tanvir.
I'm just going to keep this brief, mindful of time.
Thank you.
Last year's RES data, you have 2,000 respondents, predominantly international medical graduates, who reported about 97% discrimination in the workplace at any point in time. NHS is the biggest employer in this country, full stop. But in 76 years of its journey, it has had a poor track record in this space, unfortunately. So I think if we keep patting ourselves on our back and saying it's all hunky-dory, it's not going to provide a solution. So rather than digging into the data furthermore and having deeper dives, it's time to do something about it. And I think the first step is cultural safety awareness, and that's for our patients, for our society, and for our staff. What I have noticed over the years is that we have compassion for our patients, but we have very little compassion for each other. And, is that just the nature of the competitive landscape that we live in, or the professions that we undertake, or is it a hierarchical thing which is actually there in the background? I don't know. I haven't found the answers to that. But I realize that there are times when you have to say something. And this was this moment for me to once again reach out to all of you to push this agenda forward, because it is the need of the hour. It is no longer an abstract concept. It's not like antimatter, which you can think of but you can't see. It is now facing us, on a day-to-day basis. My colleagues are very fearful, not necessarily the Muslim colleagues, but anybody who is of color, and it applies to all health professionals. I've had people reaching out to me who haven't slept for the last week, who are sort of keeping vigil. Are their homes going to be firebombed? My colleagues are asking me, do you know of any letterbox latches that can seal the letterboxes? So I've actually researched that on Amazon, and I have sent out those links to the people who feel that way. And I've actually purchased one myself, because fire is the tool of the far right, unfortunately. So we are very vulnerable right now, and it is through this vulnerability that this conversation has happened. So I hope you all take this with the seriousness that it warrants, and push this agenda in your spaces. You are leaders, you are people of power and influence, and you can make that change. Thank you.
Thank you very much for that, and I'm sure that no one can disagree with your comments on that. Today, we're asked to approve of the 22 things we can all do to tackle systemic injustice, and I believe no one likes to face criticism, but it is time to make a difference. And as I said before, we need to own this. So I would ask if we are happy to approve this. If anyone is not in agreement, please raise your hand. That being the case, thank you. And we'll move on to the final item before any other business, which is the draft ICS People and Communities Committee Terms of Reference. And go back to Panwell.
Thank you very much, Chair, and thank you to everyone who has helped to pull this document and paper together. I'm really pleased that we've left this paper to the end, because it aptly sums up everything that we've been talking about today. At the core of everything that we've been talking about is our people and our communities. And so it's just right that we sum up the conversations today with this. For those who don't know me, my name is Fanmo Mtumburi, and I'm a senior ICB non-executive member with the enormous privilege of chairing our People and Communities Committee. You all know that we've always had a People and Communities Committee, but with some of the recent changes that have been taking place in the, we've taken this opportunity to relook at the terms of reference for the committee, especially given that it's now going to sit under the ICP. It remains an ICB committee with delegated responsibilities, but will be reporting into the ICP. So there's been quite a lot of work that has been done to look at those terms of reference to reflect some of the responsibilities that we have, not just to our ICB, but, some of the statutory responsibilities, but also responsibilities, to our communities with some of the NHSE guidance. And so I'm not going to take up much of the time, because there are people who have done, most of the work here. And so I want to hand over to Rachel Jennings, our communities lead, to sort of just take us through some of the detail around this, and then we'll come to decision. So can I hand over to you, Rachel?
Thanks, Fanwell. So as Fanwell said, it gave an opportunity to revisit the people and communities sort of membership, the terms of reference, how we're working with all of our system partners. As Fanwell has said, we've referred to NHSE guidance around how we work with people and communities. Obviously, there's also the duties that the ICB has in how it discharges its responsibilities for involvement. And then we've also looked at lots of the good practice that's been happening locally and nationally. And all of that has come together in the revisited terms of reference, which you've had a copy of. This slide here just pulls out some of those key aspects. And I guess that perhaps the change, a couple of the key things is one, as Fanwell has said, is how this very much will now report into the ICP, and that shows how we're taking a system-wide approach to thinking about how we adopt methods for co-production. And how it feels a more joined up approach. So some of the things we talked about is the central repository for how we share insight and thinking about how we have a more joined up approach to engage in certain communities who perhaps feel like they might be asked the same or very similar questions multiple times by different organisations. And the slide here just shows some of those extracts from the terms of reference and thinking about what that means on an ICB level in terms of those sort of legal responsibilities. Thinking about it as an ICP perspective and how as the ICP we can set that system approach for what does the quality look like, what's our quality standards for how we co-produce, how we work with our communities, how we have that central repository, and also how we have that central route to highlight and escalate concerns. One of the things we've done, and you'll note that in the terms of reference into Appendix A, it's by nowhere near a finished article, but thinking about there are many well-established forums, networks, informal groups, formal groups, where that trusted relationship with communities already takes place. So this is very much about how do we recognise all of that involvement, not look to duplicate it, but provide more of a joined up approach to how that information flows from things which are happening in community and at place, at neighbourhood, how that flows through to the ICP and the ICB. Place is really important. We know there are lots of really well-established communities there. And again, we're thinking, how does that tie into the committee perspective? And then also from the NHSE guidance, there's also that work around provider collaborative. And one of the things which we're really keen to move forward is an approach of insight and oversight. That's something which Sue Conker, who'll be joining us as our co-production lead, had led on with the work with the Women's Health Steering Group. I think many colleagues in the system have been involved in that. But that approach of not just having insight, but thinking about how we have that oversight and really help steer the conversations. So due to time, I think we'll leave it there. I think the final thing just to say is you will also note in the terms of reference about the membership. We are looking to increase membership quite significantly. That was where we reflected on the previous membership. We didn't feel that it perhaps represented all of the communities and that diversity of voice that we really wanted. So this is an opportunity to think about how do we broaden that. So that's one of the significant changes you'll find in there. But the request for the committee is to provide any comment and to endorse this, because this is an ICB committee. So these terms of reference will go to the ICB board in September for approval and adoption. Thank you.
Thank you for that. And the next question will be, are we happy to endorse what has been presented? And as said, any specifics can be taken offline. Any other comments or questions? Are we happy to endorse? I see no hands raised, so I will take that as read. Oh, sorry. Kathy,
you're on mute.
You're on mute.
Yeah, very happy to endorse. The only thing I want assurance of is that we can integrate district and borough involvement from Suffolk. I think we've got some references into that for Essex, and if anyone wants to get in touch with me, we can work out how we could do that.
I can see nodding of heads on both sides, and I'm sure that will happen, Kathy. So I'll take it that we're all happy to endorse. And then moving on to the final item on my agenda in front of me is any other business. Are there any questions or any other?
So there's no questions online. We've been live streaming with a few people watching during the meeting, but no questions online. Yeah, I've got a hand up.
We have one hand up. Zahid?
Hi, yes, thank you, everyone. Appreciate this is my first meeting here. So hello, everyone. My name is Wahid Khan. As was said in the beginning, I've taken over from Leighton, who was here beforehand. I just wanted to come in briefly around some of the points made by Mr. Allen around the concerns that people have in light of the current events, what's happening across the country and what's happening within our counties. I guess what I wanted to say was a couple of things. Firstly, I mean, look, from a policing perspective, you'll know there's a national kind of focus on what's going on and what we can do to try and prevent this. More locally, what I wanted to say is that we are engaging with our local community. So, Mr. Allen, I know that you said that there's a lot of concerns, a lot of fears, and I myself know that. I speak to people on a daily basis, and as of someone who's of Asian heritage, I understand that entirely. What I would say is that we've seen things develop since last weekend to where we are now. We know that there was meant to be, I'm not sure what the word is, a flashpoint, if anything, on Wednesday evening, which thankfully didn't materialise in the way that we were anticipating on Wednesday evening here in Essex. So what I would say is, I think you mentioned you live in Norfolk. That's obviously not within the area that I would cover, but what I would encourage you to do is liaise with your local officers. They should be engaging with all the communities, faith centres, all of the different areas that you would expect. I know, for example, today, that there is Friday prayers happening in different mosques, and we are looking to go out there, be proactive, be visible. So, Mr. Allen, I'd ask you, to those that have concerns, please liaise with your officers in your areas, and they can give you some advice around what's going on. What I would also say is that in the absence, where there is specific intelligence that says someone or a building or something is under a particular kind of threat, or intelligence suggests they're about to be targeted, we will of course liaise with that person directly, or that building or the owners or the organisation directly. In the absence of that, what I would ask is that we hear a lot of things online. So you'll all be aware about the list that was circulating about the targeted areas on Wednesday evening. We'll know that there's various kind of ideas about what may happen this weekend. I would urge you all please not to share or repost or retweet, information that you've come across unless you can be sure of the source. So when I say the source, what I mean is not necessarily that my friends tweeted it, so I'm going to post it again, but where did the actual information originate from? Do you know the person that's posted that information? Because social media in itself, sadly, as great as it can be, can also become the kind of can just lead to escalation of fears that we need to try and provide proportionate kind of response to. I want to reassure you all that from a policing perspective, nationally you'll know this, but from a local perspective, we are absolutely making sure that we have a high visibility presence. We have plans for key areas and sites and engaging with people throughout the county. And I'm sure the same will be for other policing areas. And throughout the weekend, as we prepare for what will be a hot weekend. But if you have any specific concerns, please contact your local areas, whoever that may be. If you live in Essex or you have anything you want to discuss about Essex, my details should be available here. If not, I'm happy to share them. Please come to me. Please visit our website. That will be able to provide you with information as well around what we're doing for the weekend. And that was it. Thank you.
Thank you for those comments. And yes, indeed, to this situation is communications and keep clarity and keeping a calm head in a hot weekend. Thank you. My final comments are: please do not forget the expo, which was taking place on Friday the 13th of all days at the Colchester Rugby Club, and the future shift, which will be on Wednesday the 25th of September. And the date for our next meeting is Friday, the 11th of October. I thank you all for your attendance today and for the excellent conversation that we've had, and enjoy your weekend. Thank you. Bye-bye.
Team left, so thank you everybody. I think we survived. I think Steve did rather well. Round of applause for Steve. That was a bit of a big ask.
Thank you. I may understand what we're talking about by 2 or 3 of these, but it is a bit daunting diving into a subject that you've not previously had any information about. I hope I didn't babble on too much. Thank you.
Yeah, well done. Brilliant. All right, then. We're going to sign off. I'll see you later, everyone.